So, good morning, everybody. My name is Andrea Borgo. I am an orthopedic surgeon. I work in Italy, in the northeast part of Italy, in Padua Hospital. So today we're going to talk about a joint and bone manifestation of mucopolysaccharidose. First of all, I have to remember that you are not allowed to take any screenshot, and yes, you can read. Please do not reproduce any slides. And I have to remember that you can send your question by the panel at the end. I'm going to answer. So, by definition, at the very beginning, what is a mucopolysaccharidosis? I know that you are maybe more familiar than me as an orthopedic surgeon with this kind of disease. It's an hereditary lysosomal storage disorder. It's caused by the deficiency or the lack of function of an enzyme that is required for the degradation of the glycosaminoglycans. And you are probably familiar more than me with this kind of biochemical classification. Here we have the name of the mucopolysaccharidosis, the eponymy, so the enzyme that is lacking, and the glycosaminoglycans that are stored. But I like to move very quickly to an orthopedic point of view. When we are facing with a patient with mucopolysaccharidosis, we focus on the short stature, the muscular weakness, the joint stiffness, ossification delay. So in the hand, the trigger finger, carpal tunnel syndrome. We have some problem in the spine, I mean the instability, the thoracolumbar kyphosis. We have some hip migration, hip arthritis, valgus deformity of knee and ankle, and so on. So I modified this biochemical classification, adding some orthopedic aspect that I divide in some general manifestation, some districtal manifestation. So we are going deeply one by one, so never mind if you are not able to learn it by heart. So I have to say that the interest from the orthopedic community is increased in the last years. No more than 10 years ago, we used to talk about MPS like a don't touch me lesion. But as you can see in this slide, I just show you that in the last literature I mean the orthopedic literature, the interest in MPS is rising more and more. So what is the problem? I have to say that starting from the lack of the enzyme to the final phenotype, the mechanism is not clear and not completely understood. We have some three major observations and some other minor observations. I mean, data from the literature are a lot, but the mechanism is not completely understood. So we know that there is an alteration of the enchondral manifestation or the enchondral ossification process, and we are going deeply in that one. We know that there is an activation of the inflammatory response, and in the future there can be also we can say that in the future maybe some anti-inflammatory drugs will be routinely used in MPS, but not for now. And so we have the glycosaminoglycans soft storage in the soft tissue. But going more deeply in the alteration of the enchondral mechanism of ossification, I like to start from this very old but very clear, from my point of view, image. We have a chondrocyte, it's a human chondrocyte, and we can see it's an Norle syndrome chondrocyte, and we can see that the cytoplasm is full with vacuoles, and all the organelles are reduced in number, are reduced in the stent, and they are displayed through the plasma lemma. Later on, we can see then some of these vacuoles open into the extracellular matrix. At the end, we have some organelles, some rosette-like deposit in the matrix. And this is the very, very beginning of the problem in MPS, of the bony problem in MPS. And this is the very, very beginning of the alteration on the enchondral ossification. So I don't know if you are familiar with the histology of a growing plate, but in a normal child, we have the reserve zone, so the proliferative zone, hypertrophic, and so on, to the metaphysis. And there is usually well organized in column organization of the growing plate. You can see on your right side the growing plate in a Harless syndrome, where this we cannot all this disarrayed, all this disorganized aspect of the histology. So this is the very beginning. So are the therapies nowadays available? Are they able to do something for the bone? We can have some from the literature, some clinical observation. We know that the ERT, the enzyme replacement therapy, leads to a faster growth, is able to reduce stiffness, to reduce weakness. We observe an augmentation in the bony mass, but there is a poor effect in the skeletal deformity. Also for the bone marrow transplant, where it is indicated, if we know if it is early, if it is done very early, it leads to an attenuation, but the deformity are still present. From the literature, we have some experimental studies in animal, and I have to say that they lead more or less to the same result. So attenuation, but not complete prevention. So at least at this moment in time, there are a lot of orthopedic aspects in the mucopolysaccharidosis. So coming back to our classification, I divide in some general aspect, and I focus later on spine, upper limb, and lower limb. So what about the general aspect? We know that the mucopolysaccharidosis, they have a short stature, and this short stature is evident from the early life, except for MPS number 2. That let's say before 8 years of age, they can be higher than average, but in the later on and in the adolescent, adulthood, they are shorter. And this short stature is a disproportional one. I mean, the shortening of the trunk is prevalent, while we have a mild shortening of the limbs. Exactly the contrary, for example, in achondroplasia, where the trunk is let's say longer and the limbs are shorter. So the stiffness is another general characteristic. Stiffness and contraction. In children, this stiffness is mostly due to the deposit of glycosaminoglycans in the articular, in the soft tissue. That's why also the enzyme replacement therapy work better in children. And the bone dysplasia is more typical of the adult. I mean, if you take an X-ray of that young girl, probably, I cannot say that the bones are normal, but they are quite normal. So the same patient, when she grew up, obviously there is an alteration, and the stiffness is not only due to the soft tissue accumulation. We commonly observe an ossification delay. And focusing on the spine, I have to say that it allowed me to show you when the problem began in the mucopolysaccharidosis. I mean, we have a 5-week embryo here, and we know that the transition between the mesenchymal tissue to the cartilaginous tissues happened very early in the life, between week 5 and week 7. So, as you probably remember, the beginning of the problem in the mucopolysaccharidosis is the alteration of the enchondral ossification. So, the problem, as far as we can see, begins very early during pregnancy. So, if we theoretically want to act with some drug, we have to start before birth, because at birth we already have some alteration, some not a reversible alteration in the bone structure. So this is the very beginning. And so we can have some mild situation, like for example in MPS number 3, MPS 3 Sanfilippo syndrome. I mean, we know that the bone involvement is not so severe, so we can have some irregular body profiles and slight spondylia, nothing more than like this. But we have some severe situation, like in MPS number 6, for example, in this young child, a female, with that is aged 3.5, and she has at 3.5 an irregular body profile, hook shape, and the early onset of the thoracolumbar kyphosis. So what can we do for this deformity? Are we going to brace it for all the life? Are we going to do a surgical instrumental stabilization? So this is not simple, but nowadays we have some the result published of a consensus conference for MPS 1, and we can say that the use of the bracing is useful to postpone the surgical treatment. It is useful to manage the postoperative period. The indication for the surgical instrumentation are mostly based in the sign of myelopathy, not in the deformity progression like we considered years ago. So, and the proper age to perform our surgery is between 5 and 13 years, because below 5 there is a high risk of implant failure, while on the other side, in late adolescence, this deformity is stiff and not easy to correct. So we can, focusing on the upper cervical spine, we can have instability or compression, or often a combination of both the problem. So we can see in this magnetic resonance that there is a compression and there is an accumulation of in the soft tissue too, and suffering of the spinal cord. Or this is a more acute patient, we have instability. So if you look deeply in detail the upper cervical spine, we can see that there is inflection and in extension, some movement between the first vertebra, leading to instability. We have some less frequent, with more rare cases, but very difficult to manage, also instability and compression between the conjunction between the cervical and the thoracic spine. Focus about the stiffness in the upper limb. We can see that there is a very severe stiffness, and if you look more deeply that there, we can see that the real abduction of the humerus, the movement between humerus and scapula, is no more than 45 degrees. She is theoretically, the appearance is that she moves 90 degrees, but there is a compensation between the thorax and the scapula. The real movement of the humerus is no more than 45 degrees. So also focusing on the elbow and on the wrist, we can see that there is no extension, no complete extension, a lack of supination movement, so the stiffness is severe. And going on the upper limb and focusing on the carpal tunnel syndrome, I have to say that I like to report the result of this study, that out of 163 patients, pediatric patients affected by carpal tunnel syndrome, 95, I mean more or less 50%, were affected by mucopolysaccharidosis. So carpal tunnel syndrome in a child is a very uncommon situation. So if you have a child with carpal tunnel syndrome, think about a metabolic disease. We can see that 1 out of 2 are affected by the mucopolysaccharidosis. So if you already know that the patient has a mucopolysaccharidosis, check for the presence of a carpal tunnel syndrome, because we can see that statistically more or less half of the patients suffer about carpal tunnel syndrome, and we can, with some surgery, we can have a significant amelioration of the situation. So I have to remember that the compression in the carpal tunnel syndrome is one of the problems, because we know that there is also an MPS-associated neuropathy. So we have to talk very clearly with the patient, with their family, because if we perform our decompression, obviously this is one of the problems in MPS. So another point is that if we are managing with MPS patient, we cannot perform such a little procedure like for healthy adults and so on, but we have to open. We do a very wide opening of the carpal tunnel syndrome. In this patient, you can see how thick is the transfer ligament, 7 here, MPS. So another point is the trigger finger. I have to say that the trigger thumb, the thumb, is not a very uncommon situation in children. Usually, we can have a trigger thumb in children aged 2 or 3 years old, often bilateral. This is not so rare. But a trigger finger, except for the trunk, is a very uncommon situation. So, in the presence of a trigger finger that is not the thumb, always think about a mucopolysaccharidosis, because it is really uncommon in a child to have a trigger finger. So, what can we do for this hand deformity that we have flexion and contracture of the finger and the thumb? There are some data from literature nowadays that we have some amelioration with some release of the pulley. The tendons are linked to the bone in some points, and we can have some release in A1 and A3 position, like I did in this child, with an amelioration of the possibility to open the fingers. So, going down in the lower limb and focusing on the hip, we, from this table that is about general aspect, but I like to focus in the hip, we can see that the hip dysplasia and the proximal dysplasia of the femur are very common in MPS. I don't know if you are familiar with this Posner outcome score, that is basically a functional score that is the target is children and adolescents, and that is able to give a global functional, but we have a subscore that is the transfer and basic motility that in some way is able to quantify the compromission of the the motility, and so the compromission of the lower limb. So in MPS patient, we have really a poor score, also in children. So, but what happened in the hip of a mucopolysaccharidosis patient? So I'd like to present this series of X-ray. This is the same patient. It's an MPS1 patient. I'd like that if you can see that we have some pattern that are going to change. So the femoral head is almost round here and is going to lose the sphericity. The acetabula is flat here and remain flat during the years. The neck diaphyseal angle, the neck between the angle between the femoral neck and femoral diaphysis, is going to increase, and so the hip is going outside. We can say that the loss of the sphericity of the femoral head, we can quantify it with this Moses technique, is very common in mucopolysaccharidosis, especially in MPS 1 and 2. And this kind of patient are going to lose the sphericity between year 3 and 8. So there's a tabular index. It's a very orthopaedic index. It's a quantification of the coverage from the acetabula of the femoral head, and so it's an angular measurement. So in the normal children, there is in the first year of age a decrease of the angular. So the femoral head is going to be covered by the acetabulum in the first year, but this is not observed in MPS. The acetabula is not going to cover the femoral head. Some work reported that it is stay like this. Some other reported that this is an augmentation, so exactly the contrary. It does happen in children, but the point is one. And so the acetabula is not going to cover the femoral head in children. So the cervical diaphyseal angle, the angle between the femoral neck and the femoral diaphysis, that in an adult normally is 135 degrees, can be a little more higher in children, but usually go down with the time. In MPS, usually we observe an augmentation. So the pelvic tilt. I know that we are familiar with an MPS patient, and usually you see that there is a forward movement of the acetabulum, of the pelvis. And so all this alteration in the hip, the neck diaphyseal angle that is higher than normal. Acetabulum is not going to cover the femoral head. The pelvic tilt lead to a progression of the luxation of the hip. And so we can quantify also this migration with this Raymar index, and we know that there is that in MPS 1 and 2, I can say there is an augmentation of the uncovered part of the femoral head. So it led to a not normal anatomy between the femoral hand and the acetabulum. So what can we do? We can perform some surgery that are, we copy this kind of surgery from the hip dysplasia, obviously, and we can have basically two kinds of surgery. A surgery that is in the proximal femur, who is aimed to put the femoral head inside the socket. It's a valgus osteotomy, like I did in this MPS 1 patient. Usually in the normal child, when you perform a valgus osteotomy, the acetabulum is going to remodel. Or we can act also in the pelvis, basically with some pelvic osteotomy, which aim is to reorientation of the acetabulum, or some acetabuloplasty with no orientation, but just adding a piece of bone laterally in order to have an augmentation of the bony roof. So, as we said, when you perform only the femoral osteotomy, there is no remodeling about in the acetabulum. So, the best result in the literature are when there is an association between the femoral osteotomy and also reorientation or some adding of the acetabulum. So, both sides. But what happened after this kind of surgery in the hips? We have only one study, by the way, and it's a long follow-up, and we have to say that the result after once that an anatomy of the hip is restored, the results are very poor. I have to say there is a progression of the compromission of the joint line. The patients are painful. We can discuss a lot if the hip score that was used here to judge the function is the proper one, because it's a score that basically was thinking for arthritis, not dysplasia. But the point is one: even if you restore the anatomy, there is a progression of the deterioration of the hip, and the patients are painful. And so at the end, they come when they are young adults, usually asking for an arthroplasty. An arthroplasty, we remove the femoral head from one side, we remove the acetabulum from the other side, and we make a total hip replacement with the two components. This is a case of mine. It's a Borgo patient and with a bilateral arthroplasty of the proximal femur. But this was quite a simple case, because there are the situation, as you probably remember, there is no roof. So it's a very high demanding surgery sometimes, and we have some solution, some wide cementation, some bone transposition and so on, but the surgery is not so easy sometimes. And also the problem is the size of the arthroplasty, because they are very short, and sometimes the prostheses that are available in the market are too large for that kind of patient, and sometimes we have to do some custom-made implants. So, lower limb, you know that all MPS patients have a valgus deformity of the knee. And we can, in children where there is the open physis, we can act with this kind of bridging. It's a hemiphysiodesis technique. We perform a stopping only in one side of the epiphysis, and we let the epiphysis to grow only on the other side, obtaining a progression during the growth of the correction. But we have to remember that these kind of patients are not growing as normal. So this kind of procedure should be done very early in life. So, and it is an example. For example, the proximal, we perform here a proximal hemiphysiodesis, because, by the way, the proper site is usually the proximal tibia. This is quite different from a normal fatty child, let's say, like this, that usually has a deformity on the distal femur. But it is the preoperative surgery, the hemiphysiodesis, the final result is a good result. Obviously, we can perform a correction of the lower limb axis also in adults with the proximal osteotomy, but it's a heavy surgery, full of metal and so on. Or we can perform the correction in the distal femur. It depends where is the deformity, like in that case, it's a Borgo syndrome. But to prevent with a simple hemiphysiodesis, it's better, obviously. Later on, this kind of patient develop an arthritis of the knee that can require a total knee replacement when they are adults. So another deformity that is commonly observed is the valgus deformity of the ankle. And in the same way we perform in the knee, we can perform hemiphysiodesis in the middle part of the tibia, like I did in this patient with a good clinical and radiological result. So later on, we can observe some degenerative arthritis in the ankle in adults, but usually the arthritis in the ankle is not so painful. So at least in my experience, they don't ask for procedure for surgical procedure. They ask for hip pain, knee pain, but not ankle pain. We commonly observe a flat foot. I have to say, I'm not to correct flat foot. I'm not going to correct flat foot in MPS patients, but I usually in soil generally or special shoes. So coming back to our classification, I underline some general aspects, some aspect in the spine, some aspect in the upper limb, some in the lower limbs, and they are here resumed. So drawing some conclusion, I mean that in this presentation I show you that the orthopedic manifestation MPS lead to disability. And an important point that at least until now, all the best therapy that we can do lead to an attenuation of the orthopedic manifestation, but there is no complete solution. The early diagnosis and the early therapy is the key for a better prognosis. I have to underline that some orthopedic signs could be the first signs of an MPS, and so also the orthopedic surgeon should be ready to not to do the diagnosis of MPS, obviously, because we have to send to the specialist, to the metabolic specialist, but to understand that some signs are not normal and need some consultation with a metabolist. And I have to say that in the follow-up of that patient, an orthopedic surgeon has to be part of the team because they are really in need of some surgical procedure in children and also in adults. So, if you have any questions, they are welcome. Okay, so there is a first question. The timing of the hemiphysiodesis in MPS patients. Okay, so as you probably understood, the meaning of the hemiphysiodesis is to lock the cartilage in one side. So obviously we should have an open physis in order to make this kind of procedure to work. So I have to say that usually for MPS 1 and 2, we can perform the surgery around 7 to 10 years. But I have to point out very, but there are some patients, especially Mucopolysaccharidose patients, MPS 4 or MPS 6, that they are not growing at all. So we have to perform this kind of surgery very early in the life. I mean around 4 or 5 years in order to have some correction. Otherwise, we have only, let's say, they are not going burst, but they are not correcting. We cannot expect any correction. So basically, the answer is 7 to 10 years in MPS 1 and 2, 4 and 5 years in MPS 1, in MPS 4 and 6. So we have another question. Okay, which are the musculoskeletal signs? Okay, so which are the most common musculoskeletal signs that are suggestive for MPS? So I have to say, first, the stiffness. A stiff child is not normal, obviously, but a stiff symmetric child with no pain, with no sign of no sign of logos, no laboratoristic sign, normal exam and so on, with a symmetric stiffness is really very suggestive of metabolic disease, especially MPS. So the stiffness at the beginning. Second is the thoracolumbar kyphosis. Thoracolumbar kyphosis in a child is very uncommon. This is not pathognomonic of MPS, could be also chondrodysplasia or other skeletal deformity, but this is very uncommon. So the another point is the carpal tunnel syndrome, as I said before. Carpal tunnel syndrome in a child is really uncommon, really uncommon. Trigger figure, not the thumb, as I say. The thumb could be, it's a common observation in children, but a finger that is not a thumb is really uncommon. So these basically are the orthopedic signs that so anesthesia and airways management linked to orthopedic patient. Okay, see, as you probably know, the anesthetic management of this kind of patient with the special referring to the management of the airways is really a challenging sometimes. But I like to underline that except for the spine surgery, all the orthopedic procedure can be basically done in a local regional anesthesia. I mean, for example, we can perform carpal tunnel syndrome and trigger femur surgery in local anesthesia, only with anesthesia of the upper limb. We can perform MEP physiodesis or even total knee arthroplasty in peripheric anesthesia. We can even perform some total hip arthroplasty in peripheric anesthesia. So whenever it is possible, think about a local regional anesthesia, because this is really safer for the patient. Try also to do some surgery in order to prevent the deformity that are going to appear later on. For example, we can perform a simple MEP physiodesis instead of waiting a lot and do, when they are already grown up, an osteotomy, because it's a simple procedure. So I'm checking for other question. Another question: is better to rise awareness to kyphosis or lordosis in terms of general orthopedics? Yes, when we have a spine deformity, I mean, in order to have a proper early diagnosis of MPS, we have to focus on the thoracolumbar kyphosis, okay? And as I said before, this is not only, there can be also some spinal dysplasia, chondroplasia, and so on. Generally, in chondroplasia, for example, this thoracolumbar kyphosis is going to get a little better without surgery during the years. But in mucopolysaccharidosis, we have no amelioration at all. So if in presence of thoracolumbar kyphosis, we have to rule out some pathologies that can be metabolic disease, can be also some skeletal dysplasia, but it is not normal to have a thoracolumbar kyphosis. Okay, so there are no more questions. So I thank you a lot for your attention, and have a nice afternoon here, or a night. It depends wherever you are, and bye bye.